Mr. Speaker, I thank you for the opportunity to speak on my assigned portfolio of health. Firstly, sir, allow me to thank the Most Honorable Prime Minister for affording me the opportunity to serve in this capacity. My cabinet colleagues for their support, and the members of Parliament on both sides for the collaboration which is so important in the interests of tackling the challenges of public health. I want to also, Mr. Speaker, place on the record my appreciation and gratitude to the team at the Ministry of Health, led by the Permanent Secretary, for their commitment and dedication, sometimes under very trying circumstances. Similarly, Mr. Speaker, I thank our bilateral and multilateral partners, individuals and organizations, both local and overseas, who give selflessly through charities, volunteers who have agreed to serve on boards and specially named committees, all energized by the shared vision of a better public health system for Jamaicans. Mr. Speaker, I use this opportunity to also thank the people of West Central, St. Catherine, and my constituency management team Without them, Mr. Speaker, I would not be here presenting to you today. And I am eternally grateful. And I say to them, the journey so far has been short, but I'm looking forward to getting to know you better and to build a better West Central St. Catherine, including all of West Central St. Catherine, including Madam Opposition Leader who hails from that part of the country. I promise to look after you around. Mr. Speaker, I use this opportunity to also recognize and thank and pray for the speedy recovery of the former Member of Parliament, Dr. Kenneth Moore. A man who has given dedicated service not just to the constituency of West Central, but to Jamaica. And I think we should recognize this. Finally, Mr. Speaker, but by no means least, I want to thank my family who are here today to give support. My wife Nadine, my sons Charles and Adam, my daughter Kimberly, who are here and who have given me total and full and loyal support. Mr. Speaker, I want to also, yes, I think I told you that yesterday. Mr. Speaker, I want to also recognize the Friendship Primary School that is in the galleries here tonight, a school from my constituency who are here supporting me. And also for those who were prompt in their attendance to the Parliament today. There was a fabulous display just out on the outskirts of the Parliament building, Port Maria Primary and Junior High, Kingston High School, NHF Summer Workers, Steps for Wellness Walking Group, Southeast Regional Health Authority, Southern Regional and Western Regional were all there promoting healthy lifestyle, healthy living, and I want to recognize and thank them for that. Mr. Speaker, research shows that healthy people make for productive citizens, and productive citizens make for a thriving economy and society. Our challenge as a country is to, in the first instance, encourage all Jamaicans to pursue a healthy lifestyle, maintaining a balanced diet which includes avoiding excessive consumption of fats, salts, sugars, tobacco, alcohol, and any other substance abuse. Secondly, in pursuit of a healthy lifestyle, Jamaicans need to encourage to be encouraged to engage in regular physical activity. Thirdly, Mr. Speaker, we need to encourage our citizens to get regular screening and checkups so that they can be aware of the status of their health. And finally, we need to prepare a public health care system, primary, secondary, and tertiary, clinics and hospitals, to adequately treat personal health issues as they occur. We also, Mr. Speaker, see as critical the Ministry's role in encouraging our citizens to live lives that encourage greater awareness of the environment and the critical link between the environment and the health of the community and its inhabitants. Mr. Speaker, we live in a globalized world where the status of our health is largely influenced by the choices one makes, how they interact with others, and how they exist within their natural environment. We may recall the spread of Ebola from Africa to the Western Hemisphere, the slow but devastating emergence of the chikungunya virus, and now the Zika virus. We also continue, Mr. Speaker, every year to battle other infectious diseases linked to hygiene, such as the flu, and in particular, and most recently, the H1N1 virus. In addition, Mr. Speaker, the impact of violence and trauma on our health services are also costly and add to the challenges of public health care provision. As a nation, we tend to be aggressive on our roads, aggressive towards each other, and unfortunately, this aggression often translates into the need for health care in our accident and emergency rooms. Mr. Speaker, additionally, the increase in non-communicable diseases continues to place great stress on our health sector. Non-communicable diseases, or NCDs, are currently the biggest threat to our health sector and economy. Diseases such as diabetes, high blood pressure, cancers, heart disease, and risk factors such as obesity continue to weigh heavily on the health system. Take obesity, for example, Mr. Speaker and colleagues. Obesity is the most common risk factor in Jamaica, with more than 60% of Jamaicans aged between 35 to 54 being either obese or overweight. Mr. Speaker, we are paying dearly for these challenges based on our lifestyle. A 2011 study by the World Bank titled Public Policy and the Challenge of Chronic Non-Communicable Diseases estimated that the direct and indirect cost for Jamaica to treat diabetes and hypertension alone amounts to some $452 million per year. These are just two of the NCDs that are of major concern. But more generally, Mr. Speaker, it's further estimated that an individual suffering from any of the NCDs spends approximately 1/3 of household per capita expenditure on healthcare services and the purchase of pharmaceutical drugs. Mr. Speaker, another study commissioned by the Ministry of Health in 2012 titled Sustainable Financing and the Reform of Health Sector to Improve Effectiveness, Efficiency, and the Quality of Care in Jamaica indicated that the country is presently undergoing demographic and epidemiological transitions. To support this conclusion, the study suggests the following, Mr. Speaker and colleagues. Firstly, with Jamaicans living longer and mortality rates declining, our citizens will have a greater lifetime exposure to non-communicable diseases. Next, non-communicable diseases, related prevalence and deaths have increased steadily across the entire Jamaican population and will continue to do so in the years to come. By 2030, the prevalence of diabetes among persons between the ages of 15 and 74 would be expected to increase by some 47%. By 2030, it is likely that the prevalence of hypertension will be twice that is observed in the year 2000. And finally, another conclusion, Mr. Speaker, the number of outpatient care cases is expected to increase by some 39%, and the number of surgeries performed is expected to increase by some 58%. Mr. Speaker, a more recent study concluded this year by the Pan-American Health Organization and conducted by the Harvard School of Public Health in 2016 indicates that NCDs and mental health will cost Jamaica some $26.3 billion, or just under $9,000 per capita in lost output each year over the next 15 to 20 years. Mr. Speaker, given all these trends drawn from these credible studies, there are certainties about the future of Jamaica's health care that as a country we need to accept and to address. Firstly, the need for Jamaicans to accept that their own health is firstly about taking personal responsibility for themselves, their lifestyle, and how they interact with their environment. Secondly, personal health care costs will inevitably increase over time due to longer life expectancy and greater risk posed by both communicable and non-communicable diseases. Thirdly, the government's capacity, this is important, Mr. Speaker, because I believe it applies to any government, whether that side or this side. The government's capacity to adequately finance public health care will increasingly be challenged unless we are able to grow our economy well beyond our current rates of growth, which is averaging 2% or less over the last 40 or so years. And finally, Mr. Speaker, a relevant, I believe, conclusion: stakeholder participation, including personal health insurance, public-private partnerships, and charities, are going to be increasingly critical to supplement government allocation towards reaching the adequate provisions of health care in Jamaica. Mr. Speaker, I started this way to make and to draw the conclusions. We need, as a country, as a people, a national dialogue to examine the future of the providing public health care in Jamaica, financing of public health care, the structure of organization for public health care provision, and stakeholder participation in order to deal with the challenges that lie ahead. Mr. Speaker, we currently allocate 3.3% of GDP from the government's coffers towards health care. And if the private sector provisions are added, we are at 5.9% of GDP. Based on international benchmarking best practices, the World Health Organization indicates that we should ideally be at 8% of GDP. In fact, while we are at 3.3% and the WHO recommends 8%, the United States, Canada, and the United Kingdom are at 17, 10, and 8% respectively. Mr. Speaker, this administration, as has been said before in many forums, is committed to universal access to health care for our people. No Jamaican should be denied access to any clinic or hospital under the public health care system if they cannot afford it. We remain committed to that principle. At the same time, it is important as a people and a country that we more precisely define what universal access means, since it may mean different things to different people, and somewhere in that mix of definitions and interpretations, disappointments and frustrations will arise. We need to clarify, Mr. Speaker, in order to adjust expectations. We must be frank and accept, for example, that oftentimes under universal access, quality is inconsistent due to limited resources, in some cases, structural deficiencies. The manifestations of this inconsistency includes long waiting times at hospitals for accidents and emergencies, surgeries and diagnostics, shortages of bed space and ICU units, and a chronic shortage of key medical personnel, such as specialist nurses and doctors, particularly in the rural parts of the country. Mr. Speaker, if you listen, you will learn. You're never too old to learn, okay? Mr. Speaker, this administration has inherited a health sector that in many ways in many ways, not in all ways, but in many ways, lacks sufficient coherence and strategic direction, and too often appears to be in denial of the realities confronting it. This is not to devalue, Mr. Speaker, the significant contribution of nearly 16,000 Jamaicans who work and make sacrifices daily to attend to the sick and suffering, who interface with hospital and clinics, but rather a commentary on the need for frank dialogue and strategic direction that recognizes our realities, projects a path for improvement, and optimizes the resources of all stakeholders to offer the best possible service to the public. In effect, Mr. Speaker, public health care provision in this country is in need of review and reform. Mr. Speaker, let me say the last administration, in fairness to them, mooted the need for reform, and we have embraced and are embracing that recommendation. So we have already commenced a 10-year strategic plan, yes, to provide a strategic direction and focus on the future of public health, given the challenges we face and are likely to face as a country. This committee, Mr. Speaker, is headed by Dr. Ernest Pate, former PAHO WHO representative to Jamaica. And the committee has commenced meeting and are working on that plan, and we will see the results in the months to come. The general objective of this strategic plan is to strengthen the strategic development planning processes for the health sector, focusing mainly on the continued rollout of the primary health care renewal program and tackling non-communicable diseases as part of an integrated health service delivery model. This strategic review and planning process will also include a policy review of the governance mechanism for the sector, and particularly the functionality of the regional health authorities, with the aim, Mr. Speaker, of defining the most efficient approach to managing the delivery of health care across the country. Additionally, Mr. Speaker, and in support of this strategic review process, a World Bank-led benchmarking cost review has commenced. This is intended to examine and benchmark the cost associated with the administration of health care in different areas, so we can get a feel of whether we are spending optimally at the different levels of healthcare provision, even with the limited resources that we have. This, Mr. Speaker, will facilitate taking the necessary steps to reapportion expenditures to ensure the greatest levels of efficiency. Mr. Speaker, we are also embarking on a number of other strategic reviews and reform processes. In the area of public-private partnerships, we are developing a policy specific to PPPs in the provision of diagnostic services, a critical source of patient weight in the hospitals, and hospital build-out and expansion, another reason for a less than satisfactory level of service. We haven't built a hospital in Jamaica for the past 25 years or so, Mr. Speaker, even while population has increased, which has placed a burden on the existing infrastructure. We are currently reviewing a report on working hours by doctors and with a view to optimizing, Mr. Speaker, patient care. These reviews will, in the months to come, create greater clarity on how we need to proceed in the provision of public health care, and hopefully will allow us to provide a better service to Jamaicans needing care in the future. Mr. Speaker, I'm a firm believer in the concept that prevention is better than cure. So before we start complaining about the insufficient numbers of beds, we need to embrace a culture of healthy lifestyle to prevent people from needing the beds in the first place. Many NCDs, non-communicable diseases, are directly related to physical inactivity. 21 to 25% of breast and colon cancers, 27% of diabetes, 30% of heart disease are all directly linked to the lifestyle of the patient, according to Jamaica Health and Lifestyle Survey. Nearly half, according to that survey, of Jamaicans are classified as having low levels of physical activity. This, Mr. Speaker, has led to an epidemic of obesity. Mr. Speaker, it is time to get Jamaica moving. Moving against obesity and NCDs. In this regard, we, Mr. Speaker, will be launching the Jamaica Moves, hashtag JA Moves for those who are on social media. Like Julia, like my member Julian. Many members. No, Julian on the right, man. National campaign. This will be an aggressive call to action for Jamaicans to become more active, Mr. Speaker. The campaign will promote, educate, and develop programs to get Jamaicans moving, both through traditional and non-traditional means. We intend to collaborate with the private and public sector entities, such as the Ministry of Education and community-based organizations, to transmit the message that an increase in physical activity reduces the risk of illness and supports the general well-being, Mr. Speaker, of all citizens. Mr. Speaker, the latest health and lifestyle survey indicated that 3/4 or more of Jamaicans aged 15 to 74 consume 1 or more bottles of sweetened beverage per day. 99% of Jamaicans are currently consuming below the daily recommended portion of vegetables. The consumption pattern for fruits was similar to vegetables in that less than 2% of individuals are meeting the recommended daily intake. Mr. Speaker, to encourage and educate Jamaicans in the principle and spirit of prevention rather than cure about proper nutrition, we will be promoting the food-based dietary guidelines in a more assertive way in the months and years to come. Good idea. This is a set of nutritional and health-related recommendations meticulously crafted and carefully designed specifically for Jamaicans. It was developed in an effort to provide nutritional and health-related recommendations to promote healthy eating and lifestyle habits among the population. It focuses, Mr. Speaker, on foods that are indigenous to Jamaica, portion sizes, food groups, and eating patterns that will provide the required nutrients to promote health and prevent chronic diseases. Mr. Speaker, we will also be revitalizing our efforts to operationalize the Food Industry Task Force towards reducing salts, sugar, and fat content in processed foods and outlining caloric values on labels so that the public can make an educated choice as to what they are eating. And Mr. Speaker, if where moral suasion will not work, we may have to create a regulatory framework starting in our schools with our children who we need to inform and educate and support so that it doesn't become habit or this unhealthy living doesn't become habit. I'm happy to announce, Mr. Speaker, that an icon in this field, Dr. Fitzroy Henry, has agreed to chair the task force, and we look forward to the early commencement and outcome of these deliberations. Mr. Speaker, I turn to an area that is debated and has been debated in recent times in this House with much enthusiasm and I dare say hype. That's the subject of marijuana. Mr. Speaker, the use of marijuana continues to be embedded in aspects of the Jamaican culture, and it remains the most commonly used illicit drug, with a lifetime prevalence of some 13% among the general population. This is according to the 2008 Jamaica Health and Lifestyle Survey. 20%, Mr. Speaker, among secondary school students, according to the 2013 National Secondary School Survey, done by the National Council on Drug Abuse and the OAS. Mr. Speaker, the average age of first use of marijuana was 12 years old, as reported from the same study I referenced above. Local and international studies confirm that there are serious implications for the health and well-being of persons who use cannabis. 90% of the adolescents screened in the NCDA's drug treatment program are referred due to problems associated with marijuana use. Moreover, treatment reports reflect, and this is important, a 54% increase in students enrolled in a ganja prevention program called Step Up since the decriminalization of possession of 2 ounces or less of ganja. Ongoing island-wide surveillance in drug treatment center also reveals that 50% of clients are in the treatment program for marijuana use or abuse. Mr. Speaker, let me just say, despite the excitement, the hype around the relaxation of restrictions and the potential benefits to society from easing of these restrictions and from the manufacturing of various byproducts, from a public health perspective, I think it is incumbent on me as the driver of public health in this country to urge caution amongst our colleagues and among the general populace. It is important, Mr. Speaker, despite the potential positives that we recognize, that we take care as legislators to balance the need to explore and experiment with the need for public education and follow-through on legislation in order to minimize the potential for abuse, particularly among our young people in the society. I think personally, Mr. Speaker, that the legislation that was brought to this House and passed some months ago was rushed, wasn't thought through very carefully, and the associated activities that should have accompanied it to protect those most vulnerable was not done. Recent amendments, Mr. Speaker, to the Dangerous Drugs Act necessitate, Mr. Speaker, recent amendments to the Dangerous Drugs Act necessitated a comprehensive strategy to address the implications of these changes for various groups in the Jamaican society, especially our young people. The NCDA, the National Council on Drug Abuse, has proposed and presented a comprehensive public education campaign to the Cabinet Ganja Subcommittee, which was accepted and should have been funded by the participating government agencies and ministries. Of the 321 million needed for this comprehensive education campaign, only 20% was received and expended. The Ministry of Health, Mr. Speaker, is the only ministry to have contributed significantly to the public education campaign, and additional funding was received from the United States Embassy through the international narcotics legislation. Mr. Speaker, I firmly believe that based on the evidence being presented here and the trends being observed, there needs to be a comprehensive relook and implementation of the amendments to the Dangerous Drugs Act, the impact it is having and will have on the health services, and that funding be urgently put in place to ensure a robust prevention and control program in this regard. And we in the Ministry of Health will lead that process in the months ahead. Mr. Speaker, a major challenge for Jamaicans who interface with the public health system is the time it takes to see a doctor and get treated. A health access study undertaken in 2013 by the Caribbean Policy Research Institute indicated that a major concern of both medical staff and patients is the length of time persons have to wait to see a doctor. This leads to both patient and staff frustration and also a lack of confidence in the overall system or the administration of public health. Mr. Speaker, over the past 2 months, this administration has conducted time and motion studies in the accident and emergency units in a number of hospitals and concluded that the majority of patients in our hospitals waited more than 1 hour just to be assessed or triaged, with some waiting in excess of 3 hours, and in extreme cases, persons waiting in excess of 5 or 6 hours. This does not include the time, by the way, Mr. Speaker, it takes to see a doctor after that initial assessment. We need, Mr. Speaker, in the interest of efficient public health care delivery, to reduce the waiting time for Jamaicans who are interfacing with our public health institutions. Mr. Speaker, as of July, we will be piloting in 6 health centers and 8 hospitals an intervention to reduce the time it takes for a patient to see a doctor, starting with the accident and emergency departments. This pilot will involve improving the process of customer service and assessment and redirecting non-emergency cases to the closest designated primary health care facility. Involved in this pilot are Cornwall Regional, Savannah-Lamar, St. Anne's Bay Regional, Kingston Public, Spanish Town, Mandeville Regional, and Maypen Hospitals, as well as the Bustamante Hospital for Children. The closest and designated health centers to these hospitals are Mount Salem in St. James, St. Anne's Bay Comprehensive and Glen Vincent in Kingston, St. Jago Park in St. Catherine, Mandeville in Manchester, and Maypen Clinic in Clarendon. These health centers, Mr. Speaker, under this program, this pilot, would have been resourced to extend opening hours to 10 p.m. at nights and equipped to provide additional diagnostic and pharmacy services to facilitate the redirection of persons who can be managed in the primary care setting from the accident and emergency rooms where they normally go for care. We will be careful, Mr. Speaker, to monitor this intervention to determine its success with the hope of rolling it out to all 23 hospitals, 24 if you involve the university, across the country. Mr. Speaker, the challenge is the clinics, the primary health care facilities have lost credibility because of short opening hours, lack of facilities. We have to make that connection again. As members would know through you, Mr. Speaker, when someone goes to the emergency room, they are given a color-coded card. And I'm not sure why it is that a red means that you see a doctor immediately and a green means that you have to wait for a very long time. But I suspect that we didn't implement that arrangement on this side. It was implemented otherwise. Because as far as I know, green means go and red means stop. But, Mr. Speaker, if you are unfortunate to get a green card, then you are likely to be waiting there to see a doctor for many, many hours. The truth is, anyone who is given a green card rightfully ought to go to a clinic, to a primary health care facility. We are going to extend the hours in those facilities and redirect them to clinics that are close by, usually on the same compound as the hospital. Mr. Speaker, we recognize that this may not impact the waiting time in some of our specialist clinics and also the waiting time for surgery. We are therefore reviewing the use of our operating theaters, including the number of effective hours they operate, state of repairs needed and equipment, and the availability of the relevant staffing, with the aim of ensuring that this resource is maximized and accordingly waiting time is reduced. Last year, this country in the public health system did 66,000 surgeries in the public sector. This performance level is inadequate based on the number of persons that are still waiting, especially for elective surgeries. Mr. Speaker, we must increase the number of surgeries performed each year in order to reduce the backlog of patients waiting for this potential life-saving intervention. I've already commenced discussion with the Association of General Surgeons, who will be working with me, hopefully, to find a way to rationalize, to increase surgery time, 24-hour cycles, which we know we have to do some work on the theaters, good lighting, better equipment, but we want to clear up that backlog as part of reducing the waiting time in hospitals. Mr. Speaker, as said earlier, I want to announce that we have received the report of the task force examining the hours and conditions of work of our physicians. And I want to thank Dr. Carl Bruce, who chaired this committee, for the work that he has done. We are reviewing this report as part of the review and reform and recommendations with the intention to hold further meetings with stakeholders and the Ministry of Finance for implementation over time. But my initial impression, Mr. Speaker, is that if implemented, this could lead to better and safer working arrangements for our doctors and an increase in the number of doctors employed within the system, leading to greater throughput of patients in some areas and further reduction in waiting time. I want to turn, Mr. Speaker, quickly, watching the clock on the wall, sir, to pharmacy services, another source of waiting in the public health care system. Mr. Speaker, the public drugs are distributed primarily through the drug serve and the hospital pharmacies. If you visit the public system, you see the long wait. If you go down Crossroads on a typical morning, 5 o'clock, you see the lines almost out on the road. Jamaicans waiting. It is almost inhumane, waiting to get drugs to deal with their ailment. We have to deal with that, Mr. Speaker. The National Health Fund has moved into some hospitals and will also begin moving into the health centers as part of our efforts to improve the delivery of pharmacy services. The idea is to have 24-hour pharmacy service in some hospitals and extend hours in some health centers. It is our aim, Mr. Speaker, to have pharmacy services in Jamaica that are technologically driven, customer-focused, and efficiently managed. The initiative that we want to pursue, Mr. Speaker, is to tap in under the public-private arrangement, tap into the private pharmacies. We have almost 500 of them across the country, one close to every hospital for sure, and close to a health center of the 320 health centers we have. We have now commenced discussion with the private pharmacies through the Pharmacy Council, where we intend, just as the drug for the elderly program and the AIDS drugs are administered through a collaboration between the government and the private pharmacies, we are moving to use the private pharmacies to improve the distribution of the drugs under the government program in order to reduce waiting time in the hospitals. In addition, Mr. Speaker, I am pleased to announce that the NHF, the National Health Fund, has approved a 100% increase in the subsidy on pharmaceuticals covered under the NHF card for beneficiaries between the ages of 0 to 18 years. These are the young people, Mr. Speaker. These young persons would normally get a 40% discount. There are approximately 10,850 such persons under that scheme. We are going to be giving them an 80% discount rather than a 40% discount, which is costing the NHF some $70 million from the $26 million annually that the NHF will pay. The approval came after careful analysis by the Medical Review Subcommittee of the Board and after verification that this initiative can be adequately financed for the foreseeable future. I want to turn to diagnostics, Mr. Speaker, another source of long wait. A CAT scan, CT scan, persons waiting, taking up a bed for a week in order to get a diagnostic service. The ministry has made several attempts at improving this area, Mr. Speaker, and over the past year there have been repairs, procurement of spare parts, routine maintenance schedule. We, however, recognize that there is still a capacity gap, not only in the availability of equipment, but also the specialists required to operate and maintain them, particularly as you move out of the Southeast region. While the Ministry of Health and several hospitals have agreements in place for the utilization of private services, there is no uniform or organized outsourcing plan. And I want to announce, Mr. Speaker, here today that we are putting in place a program to contract private providers to take up more of the provision of specialist diagnostic services in a bid to reduce waiting time, particularly for outpatient services, but also for inpatient services, depending on how we structure that arrangement. Part of the problem across regional authorities, Mr. Speaker, is that the agreements are ad hoc. What happens in one region is a different agreement in another. We need to make the process uniform, and we believe there's a lot of possibility for that. This will be done, again, under the PPP policy that we're developing, and hopefully will address some of the inadequacies in the system for things like CT and MRI and special lab services. I want to touch quickly on critical care nurses, Mr. Speaker. A major challenge that we face is the shortage of critical care nurses. Our nurses are well trained and highly respected in the Caribbean and around the world. As a consequence, we are constantly competing with recruitment agencies representing hospitals and healthcare facilities in North America and Europe, UK in particular. and this has led to shortages. We have currently, Mr. Speaker, some 137 critical care nurses in the system. We ideally need approximately 240. This year, we intend to train 50% more critical care nurses than we did last year as an attempt to try and bridge that gap. Now, the truth is that's not a lot in terms of the gap we need to make up. That's moving from 21 to about 35 or somewhere in that region. Part of the problem with training more is the practical side, the clinical side, the bed space, the availability. And we have to try to get around that, and we're exploring that possibility. In the meantime, we are going to be issuing an invitation to retired specialist nurses to come back into the healthcare system in order to try and help to fill that void. And we know several who are interested, Mr. Speaker. Additionally, where the gap still exists, we will be moving, as we have done in the past, to recruit from overseas. Now, I know our local nurses are not keen on that, and they have commented publicly. So the truth is we have patients to tend to, and frankly speaking, if we have gaps, we have to do what we have to do in order to fill that gap in the system until we can deal with it with local people. Mr. Speaker, you may have seen in the media recently that we have a challenge with bed space because of what is termed as block beds. Beds that are taken up by patients who are better but have nowhere to go. We announced a task force to deal with mental health and homelessness as part of the approach to deal with those two critical challenges. But in the meantime, we have decided to take a more assertive action in order to clear almost 300 beds that have occupants who rightfully ought to be in their private homes but have nowhere to go or have been rejected by their family members. I want to commend and recognize the Minister of Local Government, who is sitting right beside me, the member from West Kingston, who has worked closely with me on this. He has prerogative over the infirmaries across the country. We have also combined our efforts with NHF, with a major charity in Jamaica, Food for the Poor, and I'm here to say that in this fiscal year, we will be building the equivalent of 200 bed space in a number of infirmaries across the country to move these persons outside of the hospital and put them in the infirmaries so we can create some additional bed space. I've established a committee, Mr. Speaker, led by Dr. Earl Wright, who is tasked with working on this particular project, and will be moving speedily so to do. Now, the truth is we're going to have to find a way to keep those beds from being filled up by others once they become empty. And that could be a legislative issue. Hospitals are a place of safety. You can't put people out on the road, as the member knows. But we have to find other creative ways, hopefully through some sort of MOU with the infirmaries, to continue that process. We don't have enough beds as it is. We have to use what we have. I want to quickly go to electronic health records, Mr. Speaker. Let me say that we have had several challenges in the administration, in the efficiency, and as a consequence, the waiting time has been extended because of the paper-based system of electronic records and filing. Lost records have caused patients to wait long hours or to go home to come back another day. Inaccurate information, major errors that have really affected the administration of public health. This administration, Mr. Speaker, is moving away from the current manual system in keeping with the government's e-government approach, and will be moving hastily to deal with an electronic recording system for patients as a part of improving the administration of the process. I'm moving quickly, Mr. Speaker. I know you will give me an extra 10 minutes when the bell goes off. But I want to just say that already the University of the West Indies, Mr. Speaker, is digitizing their patient records. We are working with the university's management team and their projects officer, and we are using that as a basis, as a benchmark, as well as the open data digitization that started some 3 years ago at the Black River Hospital, Santa Cruz, and Darliston Health Centers, to learn the lessons from that with the hope of moving towards the medium to longer term, certainly during this administration, the digitization of patient records. Mr. Speaker, more immediately, however, we are moving quickly to improve and make a part of our daily routine the use of telemedicine technology. Telemedicine, Mr. Speaker, allows a medical practitioner to remotely
Mr. Speaker, I move that the member's time be expended by 5 minutes so that he can conclude his presentation.
The question is that the member's time be extended by 5 minutes. Those in favour? Those against? The ayes have it. Minister.
Thank you very much, Mr. Speaker. I was saying about telemedicine, Mr. Speaker. I'm pleased to announce that the advantage with telemedicine, members, obviously, is that a doctor can remotely prep and administer patient care. And in the case of a country like Jamaica, where a lot of our specialists are focused and concentrated in Kingston at UWI KPH, they could administer care in Westmoreland. Or, alternately, doctors in the diaspora who come to Jamaica frequently to administer care can use telemedicine for that purpose. A team has been assembled, Mr. Speaker, who will visit Panama, where telemedicine is a very popular use in public health administration. I've met with the Panamanian health minister when I was in New York recently, and with a local telecommunications provider here in Jamaica that currently provides the technology in Panama, with the intention of looking at how we can regularize the platform for telemedicine here in Jamaica. We are moving speedily towards that because there's advantages in that, Mr. Speaker. Mr. Speaker, when user fees were abolished in 2008, the government retained the requirement to collect private health insurance at public health facilities. Unfortunately, some hospitals discontinued doing so. We'll be moving quickly, Mr. Speaker, to ensure that collection from health card holders is a norm rather than an exception that it is today. It's not fair, Mr. Speaker, for persons who are insured use the public health facilities and, frankly speaking, in effect are subsidizing the private health insurers. And I think it's important because we need the resources. So this week, Mr. Speaker, I signed an approval for the gazetting of revised fees to be collected from private insurers who interface with the public health system. I have already met with and will continue the dialogue with the private personnel and the general insurance companies, as well as the representatives of the government personal health insurance scheme to ensure that this transition takes place smoothly and acts in the interest of better public health administration. Mr. Speaker, the measure is a precursor to a commitment that we made in the last election campaign as a party, that we intend to introduce a national health insurance scheme as part of the way forward to ensuring we can sustainably finance public health care administration in Jamaica. A team has been assembled led by former PSOJ President Mr. Christopher Zaka to deal with the feasibility of that program, and the Parliament will be updated as time progresses on that issue. I want to quickly mention charities, Mr. Speaker. Last year, we had about 200 charitable missions coming to Jamaica with an estimated value of some $3.1 million. Mr. Speaker, charities and their contribution to the administration of public health is critical to the future. We have to make it easier for those who want to give, and to give in abundance, Mr. Speaker. So 2 weeks ago, I brought a charities policy, gift and charities policy to Cabinet, which was passed. And that will be promoted and made public, but will guide how we approach the giving of gifts or encourage the giving of gifts in support of where we need it most within the system. In addition to that, we're launching a program, Mr. Speaker, called Adopt a Clinic among the charities that we have. We're going to take 100 of the 320 clinics across the country. We will maintain the personnel in these clinics, profile the needs that they have each year, and pitch it in the diaspora. A lot of Jamaicans and friends of Jamaica want to identify with public health administration. We're going to give them an opportunity to identify. Mr. Speaker, there are many other initiatives that I cannot take on now, I want to mention the final one. Public health in Jamaica, Mr. Speaker, and I recommend my colleagues to read what I have skipped out. But public health administration in Jamaica lacks a critical component to restore its credibility. And it's going to be contained in a program we want to launch called Compassionate Care. Mr. Speaker, this is not about the science of medicine anymore. It is about the psychology of medicine. Too often, when you listen to the commentaries of those who interface with the hospital system, they have nothing but bad to say about the levels of service. And the truth is, the doctors are under pressure, the nurses are under pressure, the administrators, because the system is strained. We are going to be moving towards establishing a volunteerism policy, Mr. Speaker, which is going to extend the opening hours within the hospital system and open the public health system to volunteers, under supervision, of course, in order to provide assistance for persons, particularly in the recuperation process. Combing a patient's ear, giving them a cup of coffee, reading the newspaper to them, Mr. Speaker. That will help the process of restoring compassion to public health, and we believe that we need to actively pursue that program. So, Mr. Speaker, I conclude, because my time is up, by thanking you for your leniency, thanking my colleagues for listening. There's a lot more to be done. We are ready to do it, and I call on all of us, given the challenges we face going forward, to work with us so we can provide a public health system that benefits all Jamaica. I thank you, Mr. Speaker.